I'm trying to hook up my Instagram thing, which does not seem. Why is Instagram doing this to me? If you're watching on another channel, well, that's a good thing. It says it's viewing on Instagram. Let's take a look. Is it? I don't know if it is or not. Okay. Let's see. Oh, maybe it is. Okay, go live. Edit live video. Oh, okay. Fantastic. Hopefully this is being seen. Oh, yes, I see someone's joined. Oh, thank God. Okay. I'm new with the tech, everyone. Good morning. And it is a little early, so please excuse the housekeeping real quick. Someone asked me to do slides, and you're pressing the technical abilities. And the old surgeon technical abilities are being challenged right now. But I do have slides because their point was valid. A lot of people can't take in that kind of information just sort of on the fly. And social media is not exactly set up for people to take notes and stuff. So, I mean, what the hell? I'm accustomed to doing slides professionally. That's what we normally do. Where's the little present button? Present. Haha. Okay. So now the second I hit that, I'm not going to be able to have access to the chat. Okay. Once again, I'm learning. But it is 6:00. So let me hit the button. You ought to see a full screen. And we are talking today about diverticulitis. This is probably my most common asked topic, and it's for a reason. And that is because half the population has diverticular disease. Let me drink some water, sorry. Now, not half the population is going to have diverticulitis or need surgery, but it's interesting that when I tell a patient that they have diverticulosis, at the time of a colonoscopy, everyone panics. And the reason for that is because some people, if they have an emergency with their diverticulitis, they get surgery and a colostomy, right? So that's why, do I need a colostomy is the question I get over and over and over and over again. And my answer to you is, well, sometimes yes, and sometimes no. So it really kind of depends on the patient and the presentation. So that's what we're going to alleviate some concerns. And if you have diverticular disease, and you're in that weird space where it's like, God, do I need surgery or not? At the end, I'm going to include things that you can do to prevent the need for an operation. It does not always work, but it's what we consider maximal medical management. And then I add some off the reservation kind of additives. This is the toker touch, so to speak, where and a lot of other doctors don't add the toker touch. I mean, because they just don't have the toker touch. All right, so what is it? Diverticulitis versus diverticulosis. Diverticulosis are pockets in the colon. In this picture, and I know the picture is above me in the feed, and I hope you can see it. And if not, I'm going to post this on YouTube and Rumble. And all these formats have different formatting. The struggle is real. It's a lot of work to post this stuff. But anyway, so hopefully y'all can see the picture. And if you cannot, like if every single stream that I have going right now, you cannot see this picture, I will put it on our website and I'll tell you where as a PDF. So, you can kind of scroll along because I will save it and you can watch it again later. But anyway, diverticulosis are pockets along the colon, and they happen because of chronic pressure. In particular, constipation. Some people will have, in fact, most people that I have to operate on will have this slight little kink in the mid rectum where the colon just sort of over years is kind of folded at a slight different angle. And that little kink, it's in the upper third of the rectum. If you can't unfold it, you have to remove it because that's the high pressure point. It's the one thing you don't learn as a general surgeon is that point even exists. But it does. And so colorectal surgeons do know this. So I do suggest you go see a colorectal surgeon if you have this disease, unless you're dying. The general surgeons know how to save your life. But when it comes to elective surgery, being able to do this robotically, making sure you get that high pressure point, that's our specialty. Okay, so this pressure. Now, what would the symptoms be like? How would you even know you had that? I'm going to tell you right now, half of the population has this and has no idea. It's such a chronic disease in the Western society. When you go to India, sort of Eastern society, they tend to struggle with something called volvulus, which is a really elongation of the colon. Also due to pressure, but because most of those people are vegetarian by culture, a high volume of vegetable matter has a tendency to elongate the colon, whereas chronic constipation, inactivity, processed food all tends to cause an outward pressure of the colon. These little pockets happen at the insertion sites of blood vessels. So your colon is a big long tube. It's living. It needs blood flow. And little blood vessels insert into the colon. And where the blood vessel inserts into the colon is an area of weakness. And so when the colon is under pressure, the lining of the colon, which I think I've described in other issues, this little picture demonstrates it well. You can see all the folds. The muscular tube doesn't fold like this. This is the lining that folds like this. So there's a lot more lining than there is tube. And when there's a lot more lining than there is tube, then you wind up getting like extra lining that can pop through these high pressure points and then pop out as little bubbles. I explain to my patients, think of life as, because it's associated with hemorrhoids, and a lot of people don't understand that association. So imagine going to the beach, okay, and picking up sand in your hand and squeezing real hard. As you squeeze, sand will come out between your fingers, and sand will also come out from the edges of your hand because that's what pressure does. It's looking for escape. So hemorrhoids are just the lining of the anal canal and lower rectum. They're going to bulge out this direction. Diverticular disease is bulging of the mucosa out through these blood vessel channels, if that makes sense, right? So it's pressure. The way you prevent diverticular disease is to prevent the pressure. The way you prevent diverticulitis is to prevent the pressure. Okay, so pressure is critical. What are the symptoms of just plain old, I got diverticulosis. I've never been on antibiotics. I don't know. I didn't even know I had it. What would the symptoms be? It would range from none, you have not a complaint in the world, to IBS kind of stuff. Like maybe crampy pain, you eat a salad, maybe it causes gas, you get the gas, you get the gas pain. These patients can have diarrhea and constipation that alternate. And so some of you are like, oh yeah, that happens to me, right? So they start with the constipation first, and then the dam lets loose, and here comes the diarrhea, constipation, diarrhea, constipation, diarrhea. Those patients come to my office sometimes with incontinence because of the diarrhea. And oddly enough, the treatment is not to take Imodium to stop the diarrhea. The treatment is to take fiber to stop the constipation. Things you didn't know. They almost always have, in fact, they always have hemorrhoidal disease. And if I see really bad hemorrhoids, it's a 95% certainty you've got diverticular disease because those things go hand in hand. And then, of course, you can have left-sided pain. Interestingly, depending on your surgical anatomy, have you had surgery in the past? Women in particular, if you've had children, the colon can kind of get elongated and sit across the bladder actually, and a little bit on the right-hand side. And so some people will come in like with pain just above the bladder and even just to the right of the bladder. It can be difficult to tell the difference between diverticular disease and conditions like diverticulitis, especially when it's infected. When I was an intern, now I'm about to age myself. When I was an intern, we did not do CT scans for abdominal pain. And we had a CT scanner, but that was reserved like for really special issues. Like, I mean, belly pain was just not one of them. So when someone would come in for appendicitis and you were pretty sure they had appendicitis, you had to consent that person for possible sigmoid colon resection and colostomy. Now, there is a tough sell. Talking to an 18-year-old, with pain. And by the way, you may wake up with a colostomy. Okay, you're starting to see why patients fear surgeons. And it's just because of this quandary. Now, in the modern era, a CT scan is so good at picking up diverticulitis versus appendicitis. Like, that would never come up on a consent. I can't even imagine that coming up on a consent. But back in the day, this was 30 some odd years ago. That's kind of how we did it. Now, diverticulitis. This is not a good picture of diverticulitis. It's a cartoon or computer generated. You can tell. It shows hotness. You can see the hotness in that picture. The problem is it's the wrong part of the colon they're showing inflamed. And it usually is not such a long segment. So diverticular disease usually is a very set of segment of colon. And it does occur on the left-hand side of the body, usually, not always. But typically it will occur in the sigmoid colon at a place called Solondax point, which is a point of the lowest blood flow of the sigmoid colon. And because pressure inside the colon, if it really gets severe, cuts off blood flow. And so Solondax point is already kind of a marginal blood flow. And then when you give it pressure, now all of a sudden you're going to have low blood flow, what we call ischemia. And that ischemia can lead to infection of the area, perforation of the little pockets. Now, you can have diverticulitis that's not infected, but that bleeds. And when I say bleed, I mean bleeding. You're pooping nothing but blood. And reason being, those pockets are right as the blood vessel enters in the colon. So here's a pocket. There's a little blood vessel that sits right at the bottom of the pocket. So if that pocket stretches enough, that blood vessel will burst and it will bleed, holy smokes, right? And so some people will require surgery because of bleeding as opposed to infection. A lot of times, fortunately, the bleeding stuff we can stop with interventional radiology and other types of things. So really, when we talk about diverticulitis, most people fear the rupture of the colon because there's no interventional thing for that if it's severe enough. Okay, acute diverticulitis. All right, so some of you guys who are watching, and a lot of the questions are like, oh my gosh, I just had diverticulitis, and this is what they told me, and now I'm scared. Okay, so now I'm talking to you. Okay. Okay, abdominal pain. And these patients know it kind of when it happens, usually if they have a perforation. Some people are like, it's an audible pop. If you've ever had acute diverticulitis, you may have experienced almost an audible pop. No one else can hear it. You're the only one. And the reason you felt it is it was more of a pain. Okay. Typically, again, we talked about this, usually on the left-hand side. It can be right above the bladder, and it can be on the right lower quadrant as well. This is going to be associated with fever, severe pain. Often the leading onset is constipation, pressure. Some people will have diarrhea as a reason for diverticulitis. So bizarre changes in bowel habits really tick off the lining of the colon, can lead to your diverticular disease. You can have such a severe, and this is a fascinating thing to me. Your body is, and I've already covered this. I mean, you are fearfully and wonderfully made. Like, before there was a surgeon, you either died or you survived with very unusual complications. Those complications are called fistulas. So if you rupture your colon, your body has the ability to wall it off. An abscess will form. When that abscess gets big enough, it's looking because it's under pressure also, and it's looking for weak spots. And it can find a weak spot in your bladder, in the vagina, or through your abdominal wall into the skin or into like a hernia. So these are called fistulas, and they always require surgery. You cannot poultice your way out of a fistula, right? So there's no medical management for a fistula. At some point, that's going to need surgery. And but that saved your life. So there would have been a time in humanity, and there's parts of this world with no access to surgeons, where the only reason this person survived, and I misspelled vaginal. How? How did I misspell vaginal? Look at that. Okay, I'll edit that before I post that. Ay, 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 it's early in the morning. I'll edit that before I post it. But anyway, so these people survive because of this fistula. Okay, so if you are experiencing not only kind of chronic pain, but you're passing air or stool from the bladder or the vagina, and you would know you were doing it, it could be distressing. You would know you were doing it. That's going to require surgery. And I highly suggest you find not a general surgeon, but a colorectal surgeon who can accomplish this without doing the colostomy step. The colostomy step is reserved for free perforation in the abdomen. It's not been walled off by your body. You are in septic shock and you are dying. And you need a general surgeon who's on call at the hospital to swoop into the rescue. This is what they do for a living. It's too stressful for me. I know that's what I did for a living. That's how I'm trained. It's too much. It's too much. I've got children. It's too much. Okay. Diverticulitis can become chronic, meaning you've had so many episodes of sort of mild to moderate diverticulitis that now the area is chronically inflamed. So what does that mean? There's a lot of people with that. And these are the people who really don't want to have surgery because maybe they've never needed a drain. They've never had the fistula thing. They may have never gotten IV antibiotics, but they've gotten oral antibiotics over and over and over again. With time, every time your colon gets inflamed, it will thicken. It gets thickened. That means the tube gets tighter. All that lining in your colon got no place to go, and so your colon gets partially blocked as a result. With time, chronic diverticulitis will require surgery in some patients because of blockage or chronic pain. That thickening there, can it go away? That is the mystery. Like there's going to be people I'm talking to right now like, yeah, oh, that's me. Can it go away? I have seen patients learn how to manage this condition long term, but you didn't get this way overnight. It's this thickening, you have to think of it in terms of scar tissue. If you can decrease the pressure in your colon, if you can change your ways, Rocky Raccoon, you know, who found the Bible. It's okay. So if you can change your ways, you stand a chance of at least being able to live with the chronic diverticulitis. We'll talk about things you have to do to make sure we're not missing a problem. Okay. But yes, do you have to have surgery with chronic diverticulitis? No. When you do, it's because the patient is always in pain. We can't do anything about it. We've tried everything, it's failing, or the patient is blocked. Okay. And that pain and blockage is because of the thickness. Okay. All right. Well, we talked about that, blah, blah, blah. So some of these patients will have the chronic diarrhea as opposed to constipation. If they got even slightly constipated, they're in miserable pain. This is blockage symptoms. Then they get the fistula to the bladder or the vagina. And these are the things that require an operation. Once you've got poo coming out of other organs, Just let me fix it. It's okay. We'll discuss the repair in a minute. Diverticulitis, could it be something else? Oh, yes, it can be something else. I had a friend from high school who went into the hospital, diverticulitis. They were 100% convinced that's what it was. He had a localized perforation. They drained that abscess with a drain. Everybody felt good about it. They followed up 6 weeks later with a colonoscopy, which is the standard of care. No, you're not going to get away without a colonoscopy. And he had cancer. He wasn't even 50 years old yet. So, yes, it could be something else. Probably 5% of patients with severe diverticulitis will actually have some other problem, whether it's colon cancer would be the most common, or even Crohn's disease. And I had a patient a year and a half ago where he presented with diverticulitis. We're convinced, 100% convinced on the colonoscopy and everything else, he had diverticulitis. And then we did a surgery and had a weird complication. And now we're doing the blood tests. He has Crohn's disease. And so if you've had surgery for diverticulitis and you've had a weird complication, the surgery did not heal, you got a rupture, and oh my God, now you had to have a colostomy where you were put back together, strictured. These are uncommon complications. They do occur, even if you don't have Crohn's disease. But if one of those things has happened to you, have someone work you up for Crohn's disease, because a subsequent surgery to fix that particular problem is doomed for failure unless you're being treated for Crohn's disease. So in that patient's example, when he's having the not to toot my own horn, but I never have complications. It's like 1 in 200 patients will have a complication. So when he developed this complication, it was freaking me out because that just doesn't happen. We did the test. It's Crohn's disease. Fine. I put him on max management for Crohn's disease for several months before going back into surgery and sort of repairing all the shenanigans. And it is interesting how much his body had healed what was a disaster. Now, I'm a spiritual person, and I've been praying quite a bit about him, so I feel like that helped. He was a spiritual person. He prayed quite a bit, and I'm sure that helped. But knowing your enemy helps a lot. Okay, so if you are one of these people with a weird complication, work that up. You never know. Make sure they sent the pathology for cancer, and they do. I can't think of a single person who has surgery. What just happened? Oh, why did I go back to 3? Hang on. Live. It's stuck. Hang on. I'm not going to go back to the beginning. I promise. That was story time. We had to do story time. Okay. Okay. So what to do, right? So you got belly pain. So what are we going to do? And we throw this word around a lot. Oh, you got diverticular disease because it's so common. Okay, the first thing that you're going to do is not sit at home because you're in pain. If you've got fever and pain, it is time to go see a doctor and maybe even an emergency room. Like if it's severe pain, you got a fever, you do not feel well, we're not drinking herbal tea and laying down. You got to go see somebody. This is a life-threatening disease, okay? When you get to the hospital or the doctor, you go, if you come to see me and you're not sick enough to be hospitalized, I do all this as an outpatient, but we're going to get a CT scan with oral and IV contrast. Why? So I can find inflammation. That test is incredibly good. Okay. We'll do the CT scan. At some point, you're getting a colonoscopy. I know. We have this conversation all the time. Some people don't want the colonoscopy. Why did it again? Why is it doing that? What am I doing wrong? Who's my techie in the room? I'm clicking something that okay, it's live. All right, it's live. The people watching this as a video are going to be frustrated that I didn't edit all this out, but I don't do any editing. I'm a doctor. Okay, so what to do, right? If the CT scan shows infection, you're going to get antibiotics. So if you come to my office, it's outpatient, CT scan, they see a little fluff of edema, I'm going to give you oral antibiotics. If the oral antibiotics don't work, I'm going to give you IV antibiotics. If you go to the emergency room, they'll kind of, let's take a look at you. What is your pulse? Do you have a fever? What are your labs? That will help them determine, is this an IV issue or is it an oral antibiotic and go home issue? Okay, that's how we make the diagnosis. If they send you home, well, by the time you get to go home, if they did not have to operate on you, we're going to put you on something called a low residue, high fiber diet. And I'll talk about that in just a moment because a lot of people do not get this advice. And this advice can spare you the surgery if you're on the fence. Now you're starting to realize why a surgeon talks about diet. The difference between you getting surgery and not surgery in some instances is understanding this low residue, high fiber diet. Okay, you absolutely have to have a colonoscopy 6 weeks later. We have to prove that this is not cancer. You might never need surgery. So you do not have to fear the diverticulitis and run away and avoid doctors because they're going to tell you need an operation. Okay? All right, I'm going to try to get to the next page. Okay, thank God. I think I'm clicking on the numbers. Ooh, or maybe I'm clicking on that little thing. Okay, all right. I think I got it. Okay, so now what happens if you're in the emergency room and you got a rupture? And a lot of people watching have been in these shoes as well. The first thing they're going to do is give you IV antibiotics. If you're not in septic shock, if the perforation is being walled off by your body, that it'll create something called an abscess, an intra-abdominal abscess. Then our number one goal would be to drain that pus. Can you do that without surgery? You can, actually. You can do interventional radiology and place a drain. You can do a laparoscopy. So if you're at a hospital, let's say you're in a small county and there's no interventional radiologist. Okay, I'm going to save your life surgeon. It's going to come running to the rescue, stick in a TV camera, laparoscopic, you're asleep. It is an operation. They're going to break into this abscess, drain all that infection. They're going to place a drain on top of the colon. If they can see the little area that has perforated, they'll take a little hunk of fat and lay it over that perforation. We're trying to seal that perforation, drain the abscess. Okay. You'll wake up with a drain, whether the radiologist did it or the surgeon just did that laparoscopic drainage. You're going to wake up with a drain. That drain's going to stay in place until it stops draining and a follow-up CT scan says there's no more abscess. Okay? Now, what if, oh my God, you're dying? If you are dying, they may or may not, depending. So some of these surgeons, even the trauma guys, are getting so good at robotics that they may actually choose to do this robotically. That'd be a blessing. If you're in a big city, that may happen. If you're in a country, small town, if you're super duper sick, no one's going to mess around with that. They're just going to make a big incision. Boom, let's get to the action. Remove the pus, remove the area that's infected and perforated. They'll staple off the rectal top, the top of the rectum or sigmoid colon. That's called the Hartman's pouch. They'll mark it with a suture. They'll bring up a colostomy. All that sounds terrible. That is not a permanent situation. That's a life-saving situation. And I want you to think of these stomas not as, oh my God, that's terrible. I want you to think of them as crutches, so to speak. You know, if you broke your ankle, you can't walk on your ankle. You'd be in a cast and you'd have crutches and you'd have to do that for some time. This is that for the colon. I mean, I know it seems just egregious, but this will save your life. And so that's why I want to say, don't fear the colostomy. If you can avoid a colostomy, that is awesome, but there are times where it's required. So I don't want people to be scared about that. Okay. What if the drain was successful? You didn't need surgery. Okay. You're going to continue the antibiotics, sometimes even by IV if it was really severe. Got to have the colonoscopy. You are probably going to have an operation. If you required a drain, I would say there's an 80% chance this is going to get an operation. I have tried to let people choose against it. I've tried to let people delay until, like teachers, they're like, oh my gosh, it's February. Do you think we can delay until summer? We can try. As long as you understand what the risks are, we can try. And in my hands, if there's no active infection, you are hemodynamically stable. You're not getting a colostomy. We're doing this robotically. I almost never start a surgery open. I can't even remember the last time I did that. It's okay. So you want elective surgery if you can. The purpose of that drain is to allow you to have the elective surgery. And this happens to me a lot. I get had the hospital stay. Some of these people still have a drain in place. They come to me because I do robotic surgery and I'm not going to do the colostomy unless I had to save your life. And they say, I don't want surgery. I get it. No, I mean, I'm like, I get it. Okay. How can we avoid an operation? Number one, the drain was successful. There's no evidence of pus. We remove the drain. The pus does not reoccur and you have no pain. You have a follow-up colonoscopy. It's totally normal. There's no cancer there. Cool. You have no other symptoms. Everything is awesome. We can choose observation in that moment, provided that you understand. You may have another episode. That other episode may be as bad, might even be worse than what you just went through. And that emergency can happen at any time, anywhere. So if you're on a cruise in the Bahamas and this happens, you get my point? Like this is why surgeons offer surgery. There was a retrospective study out of, I want to say it was Mass General, so the Harvard people, I believe, or maybe that was the guy giving the lecture. I can't remember. That we used to tell everyone if you had a complication, you required IV antibiotics, you were getting an operation, period. As it turns out, 9 times out of 10, your second episode of diverticulitis is never as bad as your first, which gives us the hope that we can choose observation in these patients. I just like to give patients informed consent. I'm a firm believer in that. You need to know what's going on, and therefore you need to know what your options are. So you make an educated decision. I hate seeing people make the decision they're never going to have surgery. They don't understand this concept. Maybe they never had the colonoscopy and we really have cancer. That was a bad decision. Or they had a really bad case. They really do need surgery and they chose to get on an airplane and halfway through their flight to Australia, named the longest flight I've ever been on was I love the Australian people. That is a long flight from Dallas. You're 10 hours into an 18-hour flight and you get a perforation of a colon. Guess who's looking pretty? Thank God you're going to a real place with real surgeons. But what if you were making that trip to, I don't know, some remote location on a honeymoon or whatever? I mean, odds are you're not going to find a surgeon. You can even go to Hawaii and you have to be flown to the mainland, to the main island, to find a surgeon. Yeah, I'm like, you have to be in the main. They got a bunch of islands. So if you're in Kauai and you perforate your diverticulum, that's not handled in Kauai. They could get you on an airplane, go somewhere else, because you got to have big hospital surgeons. Okay, I belabored that point. So make sure you understand what you're doing when you make your choice. That's all I'm going to say. If you fail observation, you should have an operation. And what is involved? The surgery. This is not me operating. That person is not wearing sterile gloves, nor do they know how to hold that hemostat. But anyway, it looks cool, so I chose it. Anyway, so this emergency surgery, holy smokes, right? You're probably getting a colostomy, okay? Odds are they're making a big, long incision. You're going to be in the hospital for a while, but good grief, it's going to save your life, and surgeons save lives daily doing this, okay? Many of my patients who come to see me have the colostomy already in place. And my job is to close that robotically with minimally invasive surgery with a high likelihood that everything's going to be fine. So that's my job. Elective, me. No colostomy if you can help it. Or if you've got a colostomy, my job is to close it. I use a robot. The robot does not do the surgery. One day we'll talk about what is robotic surgery. Some people have a misnomer. They keep thinking I'm like down the hall drinking my coffee while AI is working on you. That's not how it works. A robot is a laparoscopic platform where high-end computers translate my hand movements into instrument movements in a 360-degree route. So it's much easier than regular laparoscopic surgery, and the outcomes are much, much better. And so elective surgery is designed to prevent life-threatening uh, future complications. It's also designed to remove fistulas and the like. Okay. This is the reason you tuned in for 30 minutes and watch me bumble through technical problems. Prevention. To prevent diverticulitis, you want to avoid pressure. The number one thing that you can do to avoid pressure is be physically active. During COVID, diverticulitis was rampant because people were, and I won't say why that happened because that's what got me in trouble the first time around. Y'all stop it. You're making me bad. So walk. Okay, you want to be up and around, walkie, walkie, walkie. That's all you need. 30 minutes of walking per day. As a general rule, a healthy person should be doing that anyway. You're human. You've got 2 legs. And if you can walk, you should. There are a lot of people who are like, I got such bad arthritis, I can barely stand. That was me 2 years ago. There was no walking. Move as much as you can. Objects in motion stay in motion. Move as much as you can. This motion causes a torquing of your abdominal muscles, and for lack of better words, makes you fart. So you're walking and farting. And that's what decreases the pressure in your colon. You want to be hydrated. Why? Because dehydration causes constipation. Dehydration causes low blood flow. And I told you this is a pressure, constipation, low blood flow problem. So hydrate, take your fiber, walk, take a stool softener if you need to, magnesium if you're still constipated. We're trying to avoid constipation, but we don't want diarrhea. The additive things that you can do. Now, these Thursday talks are sponsored by a company called Super Patch. How do I use that in my practice? These are fascinating. And I will do a talk maybe next week. We'll talk about the science. These devices, they're like Band-Aids, for lack of better words. These devices use a tactile pattern, okay, that when you put on your skin, activates certain nerve endings. Those nerve endings tell the autonomic nervous system to reset back to normal. So the digestive tract is controlled by your autonomic nervous system. And so the 3 that I use for digestive health, one of them is called a Liberty patch, and that's for autonomic overall reset. The vagus nerve, which innervates your body, is autonomic nervous system, and the Liberty patch will help that. Stress causes increase in pressure in the intestinal tract by slowing down the upper intestines and speeding up the lower intestines. And so this peace patch, which I swear by, that is the money, slow returns that to a normal baseline. And then the intestinal tract is the largest immune system organ in your body. And the defend patch helps regulate via the autonomic nervous system your immunologic response to inflammation and stress. So those 3 things, if you're struggling, are never going to replace antibiotics. They're never going to replace your surgeon. They're not going to replace your colonoscopy. They're not going to keep you from having a colostomy. What they're designed to do is take a person who's never been on antibiotics, has symptomatic diverticulosis, and help straighten that out before they ever get diverticulitis. Does that make sense? So this is on par with like you took an aspirin because you have a headache. Okay, this is a non-medicated thing that you can do to prevent the cascade of events I've been talking about for 30 minutes. There's another company that makes a stem cell releasing agent. It's basically just seaweed. I've got links to all this on my website. And then digestive supplements and resetting your microbiome. These things are all critical early in the process. If you've had one episode of diverticulitis and you took antibiotics, your microbiome was dorked up. I highly, highly suggest that you go down the track of fiber, broaden out your dietary choices, avoid GMO foods, eat as much organic as you possibly can, get as many colorful vegetables as you can, not just green. Okay, because all of those things help promote the microbiome. Okay, I have talked too long once again. Damn it. Um, this is my website, dranatoker.com. I do have a long version, digestive health. How does the gut interact with your entire body? It's called Gut Check. Most people don't realize how tied everything is to your intestinal tract and to your microbiome. I invite you to check that out. And then if you're, if you're not ready for in depth, well, check out our free services, and you'll see that under dranatoker.com/services, and that'll be our free downloads and that sort of thing. Okay, I've talked long enough. I thank you for joining me this early in the morning, and I will try to stream that. It is streaming to YouTube right now. I'll try to put it on Rumble. It's streaming to Twitter right now also, and hopefully Instagram saves such a long video. And if it cuts off because we've been having problems with our stream, go look other places for it. And I will try to start posting these to my actual website. That way the information is yours. And if people want the slides for whatever reason, I can put that on the website. It's no big deal. All right. Hope you guys are doing well, and we will see you.